On behalf of InVivoScribe, I'd like to welcome you to our symposium. Today's first speaker will be Dr. Linda Lee. She's a senior scientist for molecular hematology at the Royal North Shore Hospital in Sydney, Australia. She has an academic and clinical trial experience prior to joining the pathology sector. The current laboratory that she leads became the first in the country as an ERIC IG certified center that offers IG and TCR clonality analysis and MRD detection by NGS under NATA accreditation. Currently, Dr. Linda Lee is developing the laboratory into an MRD reference testing facility for hematologic disorders. With that, I'll turn it over to Dr. Linda Lee.
Buongiorno. Good morning. Thanks for coming this morning. And thank you, Zachary, for the introduction. I promise you I won't overload you with a lot of data and numbers, but rather I like to share the experience that we've learned in the last couple of years that we started doing MRD testing. A bit of background on that. In Australia, we have one particular center that offers the MRD testing for hematological malignancies, mainly offering for pediatric clinical trials. But there isn't such service as a routine over to the adult population. So a few years ago, we started looking at this, and now I'm quite happy to say we offer this test, MRD testing for BOT cell malignancies to the adult population as a routine service. So essentially, you just pay me, I have no question to ask, I'll give you the result. So how do I advance? Just the green one. Okay. So for those who are not very familiar with workflow, and for those who are, please put up with the next couple of slides. I'll just quickly go through MRD testing. And the first thing we need to do is to make sure the sample is good enough for the sequencing test, because it's still a relatively expensive test compared to many other routine testing. So the first thing we look at is to look at the quality of the DNA that comes through after extraction. Sometimes we get blood bone marrow, they're easy and quality is usually good. We don't worry too much about it. However, if we do get FFPE samples as the diagnostic sample to establish the baseline and work out the sequence to follow, we do an in-house multiplex assay endpoint run on a gel, very simple, quick, if you like, even dirty. But what we want to see from that is that certain product sizes come up, and with that we decide whether the sample is good enough to proceed with the sequencing. If not, we'll issue a report to the requester, look, the sample is not good enough for sequencing, we'll try to save you a few $100. We'll stop it there. Excuse me. So I don't usually sound like Marge Simpson. For FFPE samples or samples that we think could be compromised, we go through the in-house testing DNA integrity test. And if the result shows certain bands come up but the higher bands don't, we might decide, for example, if the sample requires TCR testing, we might decide not to do TCR beta, but just go through TCR gamma. Likewise for the IgH testing as well. And just as a bonus, we offer IgK regardless of whether it's asked for or not, as long as someone asks for IgH clonality analysis. We also, sorry, get closer. Oh, sorry. So we offer the IgK regardless of whether it's asked for or not, as long as it's, the request says one IgH clonality analysis, so we'll throw in IgK as a bonus. Very occasionally, we will have a patient that is like totally polyclonal for IgH, but there is a clone for IgK. We are very careful with using those information for MRD testing. We'll go to that. So this is an example of a few samples that we've done the in-house multiplex endpoint PCR on a gel. As you can see in lane 1, all 4 bands turn out quite strongly. So that's a good sample, regardless of what you want. The entire panel can be done. And in contrast, there's in lane 3, it's totally blank. So that's the sample that we will just issue the integrity check report, but not proceed to sequencing. There's one in lane 2. The high band didn't turn out at all. And the second and third band were kind of weak. So we decided we'll just do the smallest the smallest target, the targets with the smaller expected sizes. So if it is a TCR request, we'll just do TCR gamma, and if it is RGH request, we'll just do a TCR framework 3, and IGK is usually the large one, so we ignore that one. So after we've established the sample is good enough for testing, the general scheme of the initial analysis to find a sequence that we can follow is usually just an amplification of the target based on the DNA check, if it is FFPE or CSF or vitreous fluid. Then we purified it, and it's very important to quantify the PCR product before we continue. And after that, we will equalize the PCR product before pulling into a target-specific library, and each library is also quantified again before we pull it into a final library to load onto the cartridge for sequencing. The two quantification steps we find is extremely important in getting good quality data overall in that batch. So cutting corners in those, we'll just pay for it later. So in the reagent kit that we use, each target is referred to, for example, TCR beta is referred to as target. TCR gamma is referred to a target. So in this schematic diagram, you'll see the blue ones are, on the left-hand side, the individual small circular blue ones. They are individual samples requiring a particular target. And they are first pooled after PCR into a target-specific pool, which is the oval blue figure. And when all these target-specific library has been quantified, they're pulled again into the final single pot that goes to the needed cartridge. So this is a general approach to the sequencing. Now, with the initial clonality analysis, we worked out a sequence which is spit out by the proprietary software, and based on that sequence, we'll check it to do the MRD testing if there's a need to later on. So if the patient has a follow-up sample that comes back after treatment or before transplant, we'll try to look for that, and in the process, we put a spike-in control into the PCR mix before the actual PCR. And by doing that, we established if the sample is not performing, we use the spike-in to do two things. One is to ascertain or give us some confidence the PCR actually worked. And secondly, we use that as a calibrator to work out the frequency of the sequence we are after. So there are some differences between the initial clonality analysis and the MRD detection, and I'll show you here. First of all, clonality analysis, we use one index, that's the tag at the end. And in MRD testing, we routinely use at least two indices, and how many depends on the actual sample and the actual clinical needs. Clonality analysis, we do a panel. For example, if we do IGH, we do IGH framework 1, 2, 3, and also IGK. Whereas doing MRD, we just look at one single target, or maybe two if there's a need to. Clonality analysis, we can get away with about 10,000 reads or above. We don't accept any result below 10, but with MRD, we need at least half a million, if not more. Turnaround time, more or less similar, roughly a work week or so, and we often do MRD over the weekend, so we buy some time there and reduce the turnaround time. In addition to what we normally add into the mix for the clonality analysis reaction, we have an internal calibrator, as well as in the whole batch, we include a weak positive control, and we want to see the result for the weak positive control as polyclonal, but the actual sequence that we're after, we'll look for it, and it has to be there. Now, limit of detection and the confidence of the result depends on two things, really, and we can fiddle with it to make it better. The first one is the easy one, which is the amount of input DNA, but also we can use multiple indices to increase the read depth by combining the data. Because when you set up like index 20 for the same patient, index 21 for the same patient, the sequencer has no idea you add the same original DNA template. They just analyze it, sequence it, analyze it as if they're two separate patients. But manually we can combine the data, and therefore if one sample gives me 300,000 reads, the other gives me 500,000 reads, total I have 800,000 reads, and that would help me push the limit of detection to a bit lower. There was a speaker a bit earlier on Sunday, I believe, who mentioned anything beyond 10 to minus 4 at this time is not adding too much additional benefit to patient care. But just the fact that technically we know we can do better. When there's a need to in the future, we can jump on it straight away, modify the way we do things, and change the workflow a bit to routinely produce 10 to minus 5, 10 to minus 6. We know we can do quite easily. But at the moment, we're aiming for 10 to minus 4 at least, but routinely we get 10 to minus 5, occasionally 10 to minus 6. So this is what we're aiming for. Now I'm going to show you a few very simple cases to illustrate a few facts. Case 1 is a precursor B-cell acute lymphoblastic leukemia, and it's received a sibling allograft, and we decided we will use IGH framework 3. And the original clonality analysis indicated there are 2 clones we could follow in the framework 3 targets, so we just follow the 2 clones in framework 3. The patient had very good clinical outcome after treatment. And this is the follow-up data over some months, and by the 3rd follow-up sample is down to quite low level, and essentially the patient is very responsive to the treatment, and it stays like that for some time. And since this graph was produced, we have another sample, and it's still at a very low level. So the bottom line continues just at the bottom. So this is the output from the MRD analysis, and the blue circles indicated the clonal frequency over time. And as you can see, the 2 clones that we follow just keep reducing to the point we can't pick up anymore. This is second case is a relapsed B-cell acute lymphoblastic leukemia, and again we use framework 3 to follow this patient. And at the time of the diagnosis, which was a bit under a year ago, the clone that we wanted to follow that picked up had about 80% clonal frequency. He was scheduled to have a transplant, and we are finding it a technical nightmare because the hospital sent us 0 samples over time when they were trying to prepare the patient for a transplant. Essentially, they say, look, I think I've killed all the T cells or all the B cells. Now, this is a marrow, look for them. So we're finding that a bit bordering on being rude almost, but we tried anyway. And with that, the technical challenge being there's practically no B cells for us to look for, so how do I look for the sequence? And that's when the spike-in control comes in. We will look at how much of the spike-in control, so that's all 0, how much of the spike-in control we picked up, and we use that over time. Empirically, this determined a threshold when we see at least 200 copies. We'll call that a acceptable result, even though the patient may not produce any numbers for us. So as illustrated here, he's pretty much 0 for a couple of 0 samples that sent through to us right until about 2 weeks before his transplant. So the transplant went ahead. We also try another trick. This is one of our very early cases when they try to use this test as a pre-transplant assessment on whether a patient is ready. So we forget about how much it will cost us. We actually decided to give him 4 indices. Not quite enough. We add another 2 in the next round to combine the data. It did give us sufficient read depth after 8 indices and double loading, which I'll explain a bit later. But I don't think it's sustainable cost-wise for us to take this approach in the future. And I can see clinicians actually like to send samples before transplant for this kind of assessment. So we do need to rely on the spike gene control to tell us the PCR actually works, the sequencing works. It's just that you send me a dot sample. I didn't put that in the report, by the way. Okay, so this is where we pull out the spike gene control information to show, does look, the actual reaction works, the sequencing works. So this one has a read count for the spike gene at 374, and we've determined, and there are other, if you look up the top half, there's a blue circle, it tells us the control actually passed. So empirically worked out around 200, we still get a pass result for this. So this is the third case. Interestingly, at the initial clonality detection phase, the very first sample, diagnostic sample, it was based on the algorithm, it was not a clonal sample. There was no clone, based on just the numbers. And as everyone knows here, when you determine the result based on numbers, you will always have some sitting on the fence, or just under the threshold, or just over the threshold. What do you do with them? And that's when human intervention comes in. We need to look at other clinical information and other test results to help us determine whether this is something that can be used. So this is a sample that was a request of a TCL gamma, and the criteria for calling a clone is more than 2.5%, and it's mapped to either V or D gene, and the relative difference between the suspected clone and the third sequence is more than 2, which is in this case. It also depends on the read depth as well. So the blue arrow shows you the 3 potential clones, but they're all under 2.5% of the total. So that gives you the idea of the relative frequency of the reads. We follow them anyway. This is what we get over 4 continuous, the 4 serial samples. So despite them being not considered a clone at the beginning, at the diagnostic sample, it seems to show it's still reducing, and therefore it becomes a complementary information to patient management for this particular person, although it wasn't considered a clonal sample at the beginning. So this case is a suspected acute lymphoblastic leukemia. It's determined by the algorithm to be clonal for TCL beta, gamma, as well as IgK. As you can see by the numbers in the yellow circles, this is IgK. Now IgK, we want to be extremely careful, and in fact we try to avoid using IgK for MRD testing, mainly because it's got a very high proportion of background that are non-unique sequences. So unless you're really desperate and that's your last resort, I would avoid using IgK for MRD testing. Now, choice of targets, if you do have a clonal sample and therefore a sequence to follow, TCL beta, we would try to avoid arrangements that are DJ rather than the VJs. They tend to be the less mature ones. And we want to track the exact match, so exact sequence, not 1 mismatch or 2 mismatch, and we will ignore those. TCL gamma tends to be a bit more variable, and therefore we can track 2 clones if possible, but also use the exact sequence. IGH is a lot more forgiving, and there isn't a lot of consideration you need to take into account. And you can track up to include up to 2 mismatches in your analysis. But do use the same approach every time, unless you have good reason for a particular sample that you choose not to. So in general, we avoid IgK. So this is a comparison of identical set of samples from one particular patient. We generated the NGS data, and our partner labs generated real-time PCR data. So this is comparison between 2 methods. that are quite similar in the limit of detection. NGS may be slightly more sensitive in that we can combine multiple indices to increase the read depth. The workup is quite long for real-time assay, but quite fast in NGS. In days, we could generate result, whereas real-time assay, they actually custom-made the assay for the patient. But for follow-up, we still take about 4 or 5 days, but whereas real-time PCR, you pretty much half an hour setup time, you leave on the machine and come back 2 hours later, you've got result. In terms of cost, the NGS assay is a lot cheaper at the workup stage, but more expensive during the MRD stage. However, it gives you more precise follow MRD result, mainly because we have the actual sequence to work with. And we can do multiple clones at the same time if it is suitable. Maybe just a slight touch of high sensitivity. So this is the patient that I was talking about. So over time, both assays seems to compare quite well in terms of detecting the residual disease there. We've extended the test to beyond 200 days, whereas the other lab just stopped the first time they could not find the offending clone anymore. So as you can see, we can have a bit more confidence when it comes to the level of limit of detection. We actually reported 10⁻⁵ at some point for this patient. Now, the remaining bit is really for people who work in a lab who might be a bit naughty and cheeky like us. These are not within the in vivo scribe, the manufacturer's protocol, but we find there are times we can push it a bit further to maybe reduce cost, maybe get better quality result or a bit more information, or save time. So in the instruction manual, it says do not do more than 4 targets. So you might, for example, do IGH framework 1, 2, 3, and RGK. So that's 4 targets for you. And in practice, we quite routinely add T-cell beta, T-cell gamma, as well as IGHV into the same mix, and it seems to work sufficiently well for us. So with that, we can just reduce the number of runs and have the turnaround time faster. We found out we can run diagnostic as well as MRD as long as it's not the same patient in the same cartridge. There are things that you need to massage a bit in terms of how much of what you put in, because the final library pool is quite dependent on all the targets having similar sort of amount of PCR product in there. We find freezing products quite okay, even up to a couple of weeks. So let's say if it is after Christmas, you might have 2 weeks kind of slow time, not having enough people at the work, at the lab. It's okay to freeze it for a few weeks and defrost it. We have actually re-quantified those products and proved them to be still okay. Now, double loading is a trick that we come up with to increase the number of reads for MRD samples, especially when we mix it with the diagnostic samples of other patients. By that we mean, by the time we pull the target-specific library, MRD's patient samples will get double the quantity. And we find the sequencer have no idea what we're doing, but that increases our read depth and essentially grabbing resources of the diagnostic samples to increase the yield for MRD results. This is our current setup. We found it quite straightforward to set up everything. It's still a long workflow, but we'll probably be looking at about 12 hours or so, or maybe sometimes less. It depends on the batch size at the bench, and once it's loaded, we just walked away, come back. Once the sequences the sequences are available, we'll just sit down maybe for half an hour, do a few mouse clicks, then we'll get the result out after a cup of coffee. From a bioinformatic point of view, it's very simple, and I think most labs with somewhat non-standard issue computer in your office will do the work. So it's quite cheap in that regard. You don't need a team of bioinformaticians to work with you. But you also have the choice of retrieving the FASTQ files to do more interrogation if you want to. What I find might be opportunities for improvement is to increase the workflow to within a day or even less. That would be ideal as the lab gets more busy. We think the software that we're currently using can produce more information and more easily user-friendly information display. You can put them out, but you need to know how, and it can be a bit cumbersome at times. And we would like the software to be MRD, the MRD software to be the IVD registered at some point. We find the economies of scale a bit of a limiting factor if we have an urgent case, because a cartridge costs probably around I don't know, 1,600 to 1,800 euro per cartridge for MRD testing. So if you do just one patient that's urgent, that's expensive if you add the reagent cost, if you add time and other things to it. And because everything seems to be ready to go, there's very limited scope for troubleshooting other than a few minor things that we can massage, as I described earlier. So when you look at the result output, there are a few things I think everyone needs to be very cautious about. Do not just take the numbers for granted. Do interrogate at least the graphical output to see for yourself, is it likely to be this or that? So this is the first graph that I will look at very carefully. This one, it seems to be reported as a polyclonal sample, and when we look at it a bit closer, when you look at the top most abundant clones, the percentages, they go from 6 and a bit all the way down to 1. And it seems to be a gradual slide rather than two high ones or one high ones, and then there's a cliff dropping down. So this one to us, we actually reported this one as a oligoclonal, potential oligoclonal sample, and commented in a report, interpret with caution, we don't think it's a true clonal sample. There is also a limit on the number of reactions, although I said we can put up to 7 targets into a particular cartridge to do the sequencing. But you do need to consider the total number of reactions you put in. So for my SICK cartridge, a nano cartridge that has a 0.5 gigabyte capacity, I wouldn't go beyond anything, I wouldn't go beyond 30, 35 is probably the limit. So if you have, let's say, close to 40, I'll go the next size up, even though you might be doing even 2 targets. When you have certain number of reactions, do consider the capacity of the cartridge and what you need out of it. As we indicated in an earlier case, pre-transplant depletion therapy affects your result quite substantially. So if you send a sample you suspect is one of these, do check with the referral lab or the clinician whether this is the case, so that you can adjust how you handle it accordingly. There's another, so other than pre-transplant depletion therapy, if the patient is not sufficiently recovered post-transplant, you face the same challenge, technical challenge, as the pre-transplant depleted sample. So if you do see a sample that's not performing, maybe it's worth investigating whether it's one of those cases. Now, very lastly, I think this is the most important thing in analyzing this sort of MRD data, is to interpret it within a clinical context. There's nothing worse than just taking a number and make a conclusion. You do need to consider other lab results and how the patient is responding in other ways. I like this giraffe. if you do find I'm rambling a bit too much and you have questions you want to ask after the session, do come and find me. I'd like to acknowledge that my attendance at this conference is sponsored by InVivoScript. And these are the people in the lab who has worked very hard to get our assays up and running as a written service in our hospital. And all the outputs, result outputs that you've seen so far is the InVivoScript proprietary software that's producing those results. So I shall leave the podium to the next speaker. Thank you.
Thank you for that. Next, I'd like to introduce our second speaker, Dr. Irene Della Starza. Dr. Della Starza obtained a degree in biological sciences from the University of Urbino in Italy. She then continued her education and graduated with a master's in cytogenetics and cytogenomics from the University of Rome, Tor Vergata, and has a PhD in hematologic sciences from the University of Rome, Sapienza, where she later also did her postdoc fellowship in hematology. She then began working as a specialist in the clinical pathology and clinical biochemistry at the University of Rome, Sapienza. She has been working for many years in the section of hematology of the Umberto General Hospital, dealing with acute and chronic lymphoproliferative disorders, both from a healthcare and a research point of view.
Good morning, everyone, and thanks for the invitation. Start from ALL. ALL is an heterogeneous malignancy in terms of biological profile, clinical course, and also for the management of the subject with ALL. The main feature of ALL is the presence in circulation of leukemic blast cells. The markers that define the prognosis of ALL cases are the age, the number of white blood cells, the presence of a molecular aberration, the drug resistance, and also the persistence of a minimal residual disease. The genetic profile of ALL is characterized by two forms. The chromosomal aberration that can be detected in 15–60% of ALL cases that are ideal targets because they are leukemic cell specific and are stable during the course of disease. In the second group, we have the EGTR-G rearrangement that can be detected more than of 95% and are the most frequently markers for the MRD evaluation. The MRD is the presence of a percentage of leukemic cells into a background of a normal lymphocyte, is the expression of a resistant clone to the therapy. Several methods may be used for detect and quantify the persistence of a residual disease now, such as flow cytometry, PCR-based tools, and also high throughput sequencing as a next generation sequencing. By PCR, we investigate the persistence of residual tumor cells through the amplification of a tumor molecular markers. In particular, the amplification of a DNA sequencing is always present in malignant cells and absent in normal lymphocyte, absent. The workflow by PCR method consists in several steps. The separation of broad blood by a gradient density to obtain a pellet of mononuclear cells, the extraction of DNA to screening all possible EGTR-G rearrangement combination, the sequencing analysis of all clonal products identified, and the design of specific primers on this sequence. The RQ-PCR for minimal residual disease evaluation is the gold standard currently for this type of investigation. The sequence and the primer specific for each patient that results sensitive and specific for the sequence and the clonal sequence is used for the MRD evaluation. The concept of sensitive range, quantitative range, when a sample can be defined positive, negative, and positive not quantifiable, that represent now a green zone for the biologists, but not only for the biologists, is underwent to the international guidelines of EuroMRD Consortium. And now we use this type of method. But however, this gold standard method presents some limitation because in a setting of patient between 5 and 10%, we're not able to identify a molecular marker or a suitable primer for the MRD evaluation. The clonal evolution of a GTRG rearrangement is a non-rarely event in ALL cases. The need of the baseline DNA for each MRD experiment over the time, and last, is not always able to quantify exactly the MRD level when in the sample the level is very, very low, and so define this critical sample as PNQ, positive not quantifiable. So there is the need of a new technology that can overcome some limitation, the digital droplet PCR at the next generation sequencing. In the comparison of the gold standard versus new technologies, we can see as the NGS has high sensitivity, high applicability, non-depend on azoprimer specific for the analysis, proved background information on immunological repertoire, but some limitations are the no international guidelines now, and there is the need of bioinformatic skill, and also the cost is expensive. The next generation sequencing is a complex analytic method that's able to prove a large amount of DNA of data that help us to not only have more comprehension, biological comprehensions of the disease, but give us the possibility to a better management of the ALL cases, to a better monitoring for the benefit of the patients. This is first experience of my groups in which we comparison the NGS with two other molecular methods, the RQ-PCR and digital droplet PCR. In this context, our aim was to understand if the NGS as a method could help stratified critical cases and clarify the discrepancy in between the PCR-based tools. We studied 116 samples from 44 adult ALL at 4 decisional time points. In particular, 2 time points were decisional to allocation at the patient to different treatments. In a setting of this sample, we applied the NGS study, 47, in which 21 was positive and quantifiable by NGS, and 26 was negative. The NGS quantify 11 samples classifying critical by RQ-PCR, critical as a PNQ or negative sample, and confirming digital result in 8 out of these 11. Not only 3 samples that results digital negative, NGS was positive and quantifiable with an MRD level of 10-5. In this particular setting, 5 cases experienced a relapse. 2 out of these 5 resulted positive and quantifiable by all 3 methods. On the contrary, 3 of these 5 resulted positive and quantified only by NGS and digital, and negative by RQ-PCR. The concordance rate between NGS versus RQ-PCR and digital droplets was respectively of 75% and 92%. In the second step, we decided to apply in another cohort of ALL pH negative cases the NGS at baseline for the marker screening of GTR rearrangement, and during the follow-up to study MRD by digital NGS to compare these two methods and correlate the molecular data with the two clinical outcomes. This study now is at the early stage. We screened 34 ALL sample, and 31 resulted marker positive and only 3 was negative. In these 31 sample, we decided to design a specific assay to perform MRD also by NGS, by digital. And in 5 out of these 31, we don't able to identify a suitable primer for this type of the analysis. So we decide to apply the NGS screening in another cohort to demonstrate the potential of recovery as marker screening on NGS. In this cohort, we studied by PCR for the marker screening 60 sample. 46 resulted marker positive and 14 was marker negative. In this last setting, we applied the NGS, and 10 of these resulted marker positive, with an overall recover by this type of screening of 16.7%. We now monitor at the first time point 34 sample by these two methods, and also in this case the NGS analysis showing a more quantification compared to digital, because there is the total abrogation of PNQ sample and a more rate of quantifiable sample by NGS screening, also if the size of sample now is small. Finally, the MRD assessment is carried out on bone marrow cells and sometimes also peripheral blood cells. During the last year, the study of liquid biopsy has been investigated in different fields. Cell-free DNA is a source of material, and the type of liquid biopsy is composed by extracellular DNA fragments and including also a variability across the subject and different in concentration by the location, the localization, the stage, and the sites of the cancers. The CT is a source for the minimal residual disease, also in hematological context, in nodal form where molecular monitoring has been so far impossible. We try to apply the NGS screening also in this setting in the LBCL, and we pulled starting from 4 ml of plasma we use for extraction. At baseline, we perform the PCR screening by PCR and NGS on lymph node, and subsequently we perform the MRD analysis also on cell-free DNA. As a marker, we use always IGH rearrangement. Firstly, 7 lymph node biopsies were screened by PCR results, or sample results positive for the market, but in only 1 case we are able to obtain a suitable primer for the MRD analysis. So we decide to screening only by NGS, and actually the 70 sample subject at the baseline with lymph node are screened. Also, 15 out of these 17 were also monitored by cell-free DNA. So in concluding, we try to NGS is an advanced tool able to overcome some limitation of the gold standard, have the potential to be used not only in leukemia but also in lymphoma in nodal form and in solid tumors by different source of material as cell-free DNA. But there is the need of the guidelines, the international guidelines and consensus to clarify the potential and also the benefit for the patients in terms of stratification and outcome. Thank you all for the attention.
Thank you, Dr. Irene Della Starza. Now I think we have time for a few questions.
Non funziona.
Hi.
Hi.
I'm just wondering, cfDNA is so short, how could you amplify your rearrangements on these small molecules? Are you not just amplifying white blood cell DNA, which is in your cfDNA contaminating? So which primers are you using?
During the screening, we use only the framework 2 and 3 for the cell-free DNA screening because it is fragment. When we test before the screening the cell-free DNA quality, we test by bioanalyzer to assure that there is no contamination by genomic DNA. And also in this small sequence, we able to design a specific primer.
I have a question for you. Can I ask you how much plasma you are using for cell-free DNA and how much you're inputting into the reaction?
Allora, for the plasma, we pulled 4 ml of each cases that we want to study. And we put in the reaction, independently of the concentration of cell-free DNA recovered, 10 microliters. That is the limit of the volume for each reaction.
Thank you.
Thank you.